what all a nursing does, like the most important things for nursing, one of them is giving medications. Not only are we giving out pills or doing like a shot, we're also going to be doing a lot of IV medications. Has anyone ever seen a port on anyone? Does anyone know what a port is? Okay, so you're going to see these on your patients that are going through chemotherapy or your patients that have had a lot of trauma and they're needing medications delivered as soon as possible into their blood system. Now, a port is going to go on their chest, and there's going to be a line that goes into the heart, and the line's going to end at the entrance of the heart so that when you give that medication, it goes directly there. You can get someone, like for chemo, they're going to get the chemo faster. If you're giving blood to someone, the blood is going to pump sooner. You're going to get them better faster. So what this is showing is the yellow part is actually the needle, and you can see like the needle coming out of it, and the port is actually covered by someone's skin. So you would never know someone had it unless, you know, if they're a very thin person, you could probably see the outline of a circle, but other than that, you wouldn't even know it's there. So these are put in by a surgeon, and within about 4 hours, they're ready for use. So someone comes in and there's been a trauma, like a car accident or anything like that, they're gonna start them with like a peripheral IV, getting like blood into them, and then they're gonna put one of these in to keep the line open. When people get dehydrated or they lose blood, their veins tend to get very small and it's very hard to put an IV in. So that's why it's important they have these kind of things. So this is just like one view of it. This is kind of what it looks like inside the body. Yes?
It takes like 4 hours after you get it in for you to be able to use it.
Uh-huh.
Then how is that faster than putting in an IV?
Because you're going to have the IV in and you're going to have the stuff going, but as soon as you get that port in, you can just, we call it, you can open a line. So you can open that IV all the way up and it can handle a lot more fluid than just like your little veins in your hands or in your antecubital. So if you can see in this picture how there's kind of like a circle on top of it, it's kind of like a foamy piece, and that's how you would find it on someone. Like if I had to go access someone's port and go and give them fluid, I would feel on their chest and it would be kind of mushy, and that's where I would know to put the needle. And then you pull back with your syringe, and if you get blood, you got the right spot. This is kind of what it looks like after it's been accessed. Obviously this goes straight to your heart, so this has to be a sterile procedure you do. You wear a mask, the patient wears a mask, you wear sterile gloves. That whole area has to be cleaned before you put the needle in. And then after it's accessed, we put the kind of like clear wrapping over it and then hook it up to like an IV, and that's how we give the medication. And this is something I do in the home all the time. So this isn't something that has to be done in the hospital. And then another, anybody ever heard of a PICC line? Okay, so nurses can do these. This is similar to a port, except it goes into your arm. So a lot of people that need long-term antibiotics and you don't want to be changing the IV like in their hand all the time, a nurse is going to go out and put one of these in. Doctors can put them in too, but if it's a patient that can't leave the home, we can go in and do it. So the line actually goes in through your arm, like right about here, and then it's threaded up into your heart. So what'll happen is there's things called infusion nurses, and they are specifically trained for this. They bring like an ultrasound machine out to the person's home, take an ultrasound of the arm, find where there's a good vein, put in the PICC line, and thread it all the way up through. And as they're threading it, they're kind of watching where it goes. Once someone is done using their PICC line, like once the antibiotics are done, nurses can go out and they just pull that line right out of someone's arm. Doesn't hurt, but you have to measure it when it goes in and measure it when it goes out, because sometimes it will get dislodged, and that's never good to have it dislodged. So these you're gonna probably see a little bit more than you would like a port. And I will show you, that's kind of what it looks like on the outside of someone's arm. This is also a sterile procedure. When you change the dressing on this, you have to do that once a week. The people can have these in their arms for years. A lot of times they will clot off and then you'd have to put a new one in. But you can see on the end of this, there's like 2 different white catheters. One is used to draw blood and the other one is used for the antibiotic. So, that's a PICC line.
Would there ever be a situation where somebody would have those that stand for?
Would have what? Yeah, it could be, and usually you're going to see that in like your trauma ICU. You're going to see that with someone that's going to need to have multiple antibiotics, blood going at the same time, like a very, very sick person. Yeah, so you could see it. It doesn't happen that often though, because normally you can run multiple IVs off of each one of these. They just connect at different ports of one line. That makes sense? And then this is just a regular peripheral IV. Has anyone in here had one? Go to the hospital? Yeah. It's your most common. Get fluids, medications, things like that. So those are kind of the main things that we use. Another thing with nursing, is anyone in here really get really grossed out with things or makes them faint or want to vomit? No? Okay. Anywho, so
if you change your mind while we're talking about it, just either go get a drink or
yeah.
put your head down or something.
Another big thing that we focus on with nursing is pressure ulcers. Any facility you work in, whether you're like a CNA or a nurse or a therapist, this is like, they will drill this into your head. We do not want people getting pressure ulcers. So we grade them at 4 different grades. Basically, a pressure ulcer is going to be a sore someone gets over a bony prominence. So your elbows, your heels, a lot of people get them on their butt, like their coccyx, your shoulders, I'm trying to think where else I've seen people have them, their hips. And it's basically, you're going to see it a lot in your elderly that are very thin and frail because they don't have that fat cushion. And so their bone is just rubbing on their skin. So basically it's just breaking that skin down. So the first grade of a pressure ulcer is going to be that top one, and it's just basically redness. You know when you have a red spot on your body and you press it and it makes like a different color and then it goes back to being like red? Well, with a grade 1, you're going to press it and it's not, the color isn't going to change. It's just always going to be red. So with that, we're automatically going to start putting like pressure ulcer cream on it. We're going to keep repositioning the patient, trying to keep them off wherever it is. Say it's their hip. We're going to do everything we can to keep them off that hip because we don't want that skin breaking down. So a grade 2 or a stage 2 is going to be where like the top layer of skin is gone and it's red, it's shiny, and that one you can still put cream to, but we might also add like a different dressing, and those are called like gel dressings. They kind of form to the skin. Third one is going to be pretty bad and pretty painful. This one is going to be like you've lost the entire top layer of your skin. So you're going to see like the fatty tissue, which is like yellow. Usually those ones, you see a lot of those on like the buttocks. I mean, that's just a big area. So for that, you're going to have to do like wet to dry dressings, which basically you're packing the wound with like gauze and then putting like a dry dressing over top of it. Then the fourth one is going to be the skin is so broken down that you are seeing bone, and you can see tendon. If you can see like the far left picture here, how it's black on that area, that is what we call necrotic tissue. So that is basically all, that tissue is dead. It is not viable anymore. So if I came into a home and I saw that, I wouldn't know what is underneath that because it's black. So at that point, that black part would have to be removed to find out like how deep does this wound go. So I mean, you could remove that and it could be all you see is bone or all you see is tendon. So at that point, that's when you need to get usually like a wound specialist involved to take care of how are we going to get the skin to grow back. And a lot of times it's not going to. A lot of times there's been too much damage, especially with your elderly. A lot of times when people get older, they lose their appetite, they're not eating as much protein, and the body just isn't going to regenerate like it should. Like as if one of you guys got a wound, you guys would heal fine. The elderly, it doesn't happen that way. So, like I said, these are extremely important. Whenever a nurse goes in and has a new patient, they will do a head-to-toe assessment, which basically you start at the head, you go to the toe, you examine everything. You look over every inch of their skin and make sure you don't see this, because if you miss it, it could lead to a grade 4, and then there's going to be a lot of complications involved. So this is, like I said, like one of the major things that we always look for. You're going to see it a lot with like paraplegics, people that don't move as often, so you're going to want to make sure you reposition them so they're not always laying on the same side. Any questions about pressure ulcers? No? Okay. Okay, so then,
Are you looking them up?
I had to. It wasn't good enough.
yeah. So, yeah. So, basically, the main thing a nurse is going to do in anywhere she works is going to be a head-to-toe assessment. And this just kind of shows, it's hard to read, it's kind of a bad picture, but it just shows that like when you start at the head, you're going to look at the eyes, you're going to see, are they bloodshot, or is the sclera white, do they have a runny nose, you know, do they have a white coated tongue, does it look like they're hydrated, you're going to listen to their heart, their lungs, their stomach. Main thing too is always check pulses. You're going to check their carotid. You're going to check your wrists, you're going to check behind the knees, and you're going to check the feet. If a pulse is weak, that means that they are not getting enough blood flow to that area of the body. I told a class earlier, there was a guy I went out and saw, and he kept complaining that like his foot was really cold, and he could not get it to warm up, and he didn't know what was wrong. So I check his pulse on his foot, and there is no pulse. So he was not getting blood flow at all to his foot. He ended up having to have his leg amputated. So these are all things that you want to check when you go in and see a patient. Yes?
Isn't that really common in patients with diabetes?
Yes, it is. Good. The main thing with diabetics is if you've been a long-term diabetic, they get what's called neuropathy, which is they can't feel their toes or their feet. So if they were to like stub their toe, they would have no idea that they did that because they can't feel it. So then they get an open wound. They're not treating it, then they get infected. When you're diabetic, it's hard to sometimes fight off disease, and then the next thing you know, it's more complicated. So, that's that. I did bring some of the equipment I work with daily. I don't work in a hospital or a facility, so I kind of have to carry what I need in a bag with me when I go to like the different homes or nursing facilities. So the most important things I have are my stethoscope to listen to the heart and the lungs and the stomach. And then I always have a blood pressure cuff. The one thing, if you ever go into nursing or into healthcare, is vital signs are going to tell you the most of what you need to know at the time. So vital signs are the blood pressure, temperature, pulse, oxygen. If any of those are off, you know something's going on. You just have to find out where it's going on and like what it is. So someone's pulse is really high, their blood pressure is really low, and they've just had a surgery, there's a bleed somewhere. That's a sign of someone bleeding. So it's always important to have your equipment with you. And has anyone ever seen a pulse ox? Okay, yeah, just goes on your finger like this, shows you what your oxygen is and your heart rate. Another thing I always have is a face mask for CPR. This just, if I were to go into someone's home and they were on the floor and they weren't responsive, automatically you're going to start CPR. It's always nice to have one of these because then you're not directly doing mouth to mouth. It just goes over their face like this. And then when extra help comes, they can just attach a bag to this pipe right here and start doing air while you're doing compressions. So this is always important to have. And a couple other things. Any questions so far? Am I going? Everybody okay? Okay. Another thing, anybody in here heard of blood clots? Yes? Okay. So, a lot of times when people get older, they can get a heart condition called atrial fibrillation, which is where the heart beats really, really fast. And so when it's doing that, the blood flow isn't getting through the heart. So it's kind of pooling in the heart. When that happens, blood clots can form. So if they get diagnosed with that, then they'll be put on a medication called Coumadin, and that will thin their blood so they don't get clots. Yes?
Yeah, my mom actually had a blood clot and she takes Coumadin. And,
Yes.
She had it like right behind her knee.
Mm-hmm.
And she forgot what I was gonna say.
Was it painful?
Yeah,
Painful
she
and
was
red?
petrified.
Uh-huh. So it's genetic.
Yeah.
So, and when you get, a lot of times your blood clots are going to form in your leg, and how you'll know is all of a sudden your leg's going to be really painful. It's going to hurt to walk. It'll swell up. It'll be like hot to the touch and really tender. And if that happens, I mean, you need to go to a doctor immediately, but they'll start someone on Coumadin, or warfarin is a different name for it. And what I'll do is if they're home and they can't get to a doctor, I can come out and test their blood. And this is called a CoaguCheck machine. It looks just like a glucometer. I don't know if anyone here is diabetic or has someone in their family that's diabetic. But all you do is turn this machine on.